Okay. Okay. Because of time, so I think we cut the coffee break this moment. So I'll give another lecture talking about the emergency condition, about the status epilepticus and acute resuscitation. So I think you guys all very happy. I think if Mary had a question about what kind of anti-epileptic drug can reduce weight, I think all of you can correct, 100% correct. Okay. So uh, let's introduce myself first. I'm currently an associate professor and director of the Department of Neurology in Taipei Medical University. And I am very happy to come back again. In 2019, I have a short stay to join the Taipei Medical Mission for that time I was very lucky to join the Butimba. Okay, it's okay. Okay, thank you. Thank you. Thank you. And now, 3 years later, after the stabilized, I think stabilized the COVID-19 pandemic, I came back to work with our colleague at our medical mission here. Uh, so, what do you think about status epilepticus? It's an emergency condition, medical emergency condition. So if a patient you suspect or diagnosis as status epilepsy, you have to manage it as soon as possible to reduce the morbidity, mortality, and complications. So I think you already seen the movie from Dr. Liu. There's a shaking hand, shaking arm. Actually, the seizure usually stop within a few minutes. They can have the aura phase, like Dr. Liu said, it can be sensory or music induced or any other kind of symptom. And the tony phase, the muscle spasm, and cony phase, you see the convulsion. And after that, the patient will enter post-sequel phase. Sometimes the patient may have sleep and drowsiness for a while. So this is the usual seizure happen in a patient. But sometimes the seizure may last for longer. So in 1981, the International League Against Epilepsy, ILAE, has raised a definition for the status epilepticus to notify the serious condition of continuous seizure. So that's time the definition is persist for sufficient length of time or is repeatedly, frequently enough that recovery between attacks does not occur. So the seizure can continue for a long time or can be repeated attack without regain of consciousness or regain to the functional baseline. But after several years later, the 1993, the Epilepsy Foundation gave a definite, more clear definitions, 30 minutes. So a seizure lasting 30 minutes, we call it status epilepticus, or there's no recovery between two attacks. For the status epilepticus, we can classify as two types. One is convulsive type, the other is non-convulsive type. Depend on you see the muscles twitching or not. For convulsive status epilepticus, it can be prolonged or repeated tonic-clonic seizures and requires urgent medical treatment because when the patient has a convulsion, they might have interfered breathing or self-injury and may cause some severe complications. For non-convulsive status epilepticus, it usually is a long or repeat absence or focal impairment of awareness, just like the video, the child with absent seizure cannot for a few minutes unresponsiveness and soreness of mind. That can be a non-convulsive status epilepticus. So the epidemiology of status epilepticus about uh, 7 to 40 cases per 100,000 persons a year, and it's more common in male. And there's a sufficient population have a history of epilepsy. So status epilepsy can should be aware in those patients already has epilepsy and under treatment, because many of the cases with status epilepticus might due to the poor compliance of drug and they did not take the enough drug or something. And the short-term mortality within 30 days of status epilepticus can be range from 7% to 22%. So it's a very serious condition. We have to notice that. So for the diagnosis of status epilepticus, there's four axes from the semiology, etiology, and the electroencephalography takes an important role because we have to use EEG to monitor the treatment efficacy and also the different age can affect the different type underlying cause of status epilepticus. So how about the time is important for status epilepticus? This is because for tonic-clonic seizure, if the seizure lasting more than 5 minutes, those kind of seizure can be leading to continuous seizure activity. And if it's lasting for 30 minutes, that can cause neuronal damage and even neuronal death and the alteration of neural network and the functional deficit. So that's very important for time. For the treatment of the management of epilepticus status epilepticus is very important is time. Time is the brain. And for focal status epilepticus with impaired consciousness, there's 10 minutes and more than 60 minutes. And for some status epilepticus is 10 to 15 minutes. So how our neuron will become unstable? This is a theory. We for epileptic patient, there's some neuron is very active to firing and the signal will transmit through the cortical pathway to distant cortical area. But if we just limited on and restricted cortical area, they will not affect too much. But if it is spreading to the thalamus or hippocampus, because there's a reciprocal feedback loop connection between the cortical area and the thalamus and the hippocampus, so this can be an amplification of the stimulation signal in the neuron population. So that can be caused status epilepticus. Also, there's a molecular mechanism can result in the over excitation of the neuron, including there's a decrease modification degree use of postsynaptic GABAergic. We all know this GABA neuron is inhibitory role in very inhibitory role in the nervous system, and also there's NMDA receptor mediated, resulting in calcium flow increase and enhanced AMPA and glutamate receptor activation. We know that the glutamate is an excitatory amino acid in neurotransmitter in the brain, so it can be reduce the inhibition and enhance the excitation to result in the worst cascade. So for the time frame, for the protein phosphation is occurs only millisecond or several seconds, and for the receptor trafficking, it takes about second to several minutes. And for neuropeptide expression, it takes about several minutes to several hours. So when a seizure occurred, we the better to stop as soon as possible, because those kind of abnormal brain neuronal activity can induce protein phosphorylation and subsequent receptor trafficking and inward then reduce the GABA and enhance AMPA, then cause the status epilepticus. So when to treat? If the treatment within 30 minutes of onset, about 80% will be responsive to first-line anti-epileptic drug, like the Mary says, those first-line anti-epileptic medication. But if the therapy start beyond 2 hours windows, there's only 40% respond to the medication. So that will cause severe alteration of the functional status or even the neuronal damage. This is the American Epilepsy Society proposed an algorithm for convulsive status epilepticus time frame and the treatment. I summary is the right side. We separate it 4 stages. The first stage is according to the time. The first stage is within 5 minutes. At this time, when the patient have seizure non-stop within 5 minutes, we at first we have to ensure in emergency setting we have to ensure the ABC, airway, breathing, circulation, and also give the oxygen, and also set IV access and check the glucose. Check the glucose because some adults may be due to the alcohol related seizures that may not stop. So for if you check the glucose below the 60 milligram or 3.5 millimole per liter, you have to give the glucose as soon as possible. For adults, we can give the 100 milligram thiamine plus 15 ml D50 water. But for children, we give the 2 milligram per kilo D25 water or 4 milligram per kilo D12.5 weight. Yeah, so this is the first stage. But at this stage, we have to give some medication if it's not stopped. So the initial therapy for the continuous seizure, convulsion seizure is benzodiazepine. We have 3 choices. There's midazolam IM, lorazepam IV, or diazepam IV. If we cannot have those 3, we also can use phenobarbital is the level A evidence, and the diazepam is rectal diazepam is level B evidence, and also the intranasal or buccal midazolam is level B evidence. But if the seizure still cannot control with the first line initial therapy with phenodiazepine, uh, in the 20 to 40 minutes, we have to use the second line therapy, including the valproic acid, IV 40 milligram per kilo, maximum 3,000 milligram is a level B evidence, and the phenytoin IV 20 milligram per kilo, and the tiracetam IV 60 milligram per kilo, maximum 4,500 milligram. So, and if those three cannot available, still can use the phenobarbital IV 15 milligram per kilo is level B evidence. But if beyond the 40 to 60 minutes, this can be, we can repeat the second line therapy again to give another bolus, and also may consider some anesthetic dose of theopento, midazolam, or phenobarbital or propofol. But those kind of cases, we have to need to intensive care, and it's better to have a continuous EEG monitoring to see the effect. So after the 2016 criteria, there's still a little modified to define the stage of status epilepticus according to the time and the severity. So for the stage 1 is early status epilepticus is first line AED, phenodiazepine is enough. But if not stop, you go to the established status epilepticus, you should have to urgent control and with secondary line therapy, for example, like phenytoin, valproic acid, phenobarbital, midazolam, or tiracetam. And then when if the second line cannot control low seizure, we call it refractory status epilepticus. This time, we need to add further medication like the general anesthesia, propofol, continuous midazolam drip, and phenobarbital. For refractory SE, when we use those agents, we need respiratory assistance because those medications are severe have a severe effect on the respiratory inhibition. But if the seizure cannot stop within 24 hours, we call it super refractory SE. So for this kind of case, we should continue the general anesthesia and consider other alternative therapy like the hypothermia, ketamine, or lacosamide, and other medications. So, but what is the etiology of status epilepticus? The most top one cause is discontinued anti-epileptic drug. So if a patient with epilepsy, we have the most important thing is to adherence and not to discontinue the drug as if you want. So it's important to educate the patient because it's if it is continue the medication, it will put in a dangerous condition to become a status epilepticus. And the treatment algorithm was modified to add the management of super refractory status epilepsy like this. This is published this year in Anesthesia Journal supplement. So we can see that for the first 1, 2, 3 part is similar to the previous one, but there's some measurement we have to do when we give the patient medication. for the second part, when we give the AED within the 5 to 20 minutes, we have to look for the possible etiology and the possible reversible cause of the seizure. So that's what very important, because if you are not correct those underlying problems, the seizure will continue and cannot stop with simple agent. So very important thing is find out the underlying cause, and also when the seizure the second line medication is ineffective, so you have to shift to the third line general anesthesia as soon as possible, and also at this part we have to in treat patient in the intensive care setting. And also, when in patient in refractory seizure or super refractory seizure, we have to need an EEG monitor to monitor the medication is effective to suppress the brain abnormal brain activity or not. Then we can taper the general anesthesia or other medications slowly. So the next, when we treat the primary, we have to see is any diagnostic problem or any underlying cause. For most common problem is low level AED. I think I have mentioned several times. This is the first important things is because the patient has epilepsy, but they don't want to take the drug. Then in ICU, there's maybe due to the metabolic problem or drug withdrawal. So if a patient in ICU, the patient may not have a previous seizure, you have to check the metabolic problem. And also in the coma patient, that's maybe due to the non-convulsive status epilepticus. We will talking later in the slide. And also the persistent electrographic seizures can persist about 20 to 40% of clinical susceptibility. So continuous EEG monitor is important when the patient, if the patient enter the refractory seizure or super refractory seizure, to monitor the drug effect. And also there's in suspected non-convulsive seizure and altered mental status or in coma patient. So there's an alternative if the patient enter into the intractable status because we have several options, but it's dependent on the patient condition, and you can use add-on other anti-epileptic drug or immunotherapy or other method to stabilize the brain. Why do we use the immunotherapy? That is because the underlying cause. I show you a patient. I have a patient with the status epilepticus. He is robust. He is salesman and very well healthy before, but he has a conscious change and psychosis and became the status epilepticus and admitted to the ICU. And later on stay on the general ward for half a year. But he can, after that, he can recover, but he still have some sequel after the status epilepticus. I think maybe some of you may have seen the movie called Brain on Fire. Brain on Fire. It's based on a true story. It's describe a patient have the anti-NMDA receptor encephalitis. So the prognosis of status epilepticus is not good. So we have to treat as soon as possible. For the mortality rate in hospital discharge about 9% to 20%, and 30 days mortality can even higher than to 27%. And for the refractory status epilepticus, the mortality can reach 60%. So it's very dangerous condition when we have the patient with status epilepticus. And also the complication can present in the patient with status epilepticus, for example, like a stroke or metabolic problem, hypoxia, or system infection, or nausea. So our treatment goal is to cessation of convulsive seizure and the brain activity, the suppression of the EEG activity. Uh, Even when we reach the EEG get suppress the epileptic activity, most experts will recommend continue IV AED for at least 24 to 72 hours after it's get the electrical activity get normalized, because sometimes it can be recurred when you stop the medication. So the next topic is non-convulsive status epilepticus. So those kind of patients, you can see the frequent epileptic discharge on the EEG, but the symptom can vary differently. For example, like this woman is just mild drowsiness, the underlying cause is because of hypertensive encephalopathy, cause posterior reversible encephalopathy syndrome. There's and for this case, it's a typical absence status. You can see that there's a whole the EEG. There's abundant epileptic discharge over over there. So the patient express a pounded and withdrawn and inadequate reaction for 3 weeks. So after proper treatment, the patient recovered from the previous condition. And but sometimes it's not so lucky. For example, like this EEG, you can see still the continuous and abundant epileptic activity. This is a 66-year-old man with cold cardiorespiratory arrest. So his outcome is very poor. But also this case is very poor. So EEG is, although we see the continuous abundant epileptic activity in the EEG, the patient may have expressed differently. The patient may have just like drowsiness, or like a slow augmentation and slower response, can respond well. Uh, After proper treatment, the patient will return normal. But sometimes the patient can be cause coma and even go to the grave. So the non-convulsive SE in a statistic of the United States is about 63% of SE are non-convulsive status epilepticus. And also in a prospect study of 236 coma patients without clinical evidence seizure, there's 8% patient meet the EEG criteria for NCSE. So those patients, if you give the proper treatment, the patient will wake up and say hi to you. So this is very important when we are seeing patient when the conscious disturbance, we may consider it NCSE. And there's some symptom, positive symptom and negative symptom. We may notice the possibility of non-convulsive seizures. For positive symptoms, the patient can be agitation, aggregation, or there's just blinking, crying, laughter, delirium, or echolalia, or even tremulous. Those can be positive symptoms. The negative symptoms, the patient can express amnesia, anorexia, catatonia, confusion, even coma. So the spectrum is very wide. So for the diagnosis of non-convulsive status epilepticus, we largely depend on the EEG because the patient may not look like the leg shaking. You can see clearly. So you need the EEG. So in 2015, there's a suspect EEG criteria for diagnosis of NCSE. This is according to the epileptical discharge, if the frequency greater than in EEG, there is a greater than 2.5 cycles per second, you can diagnose as NCSE. If less than 2.5 cycle per second, then you have to check if the AED effective. If you give the AED, the patient the symptom disappear and become normal, the functional can return to baseline. We still see the possibility of NCSE. So the prognosis of non-convulsive status epilepticus can be very different from the very good prognosis to very poor prognosis, depending on different type of the non-convulsive status epilepticus. For example, like absence status epilepticus, those patients might have just interfere the communication with others, but those patients still need to treat because sometimes the non-convulsive status epilepticus can transform to the convulsive status epilepticus and cause the injury. And the worst part is the coma with generalized electric activity or coma with lateralized epileptic activity. Those can cause the epileptic brain dysfunction and structural brain damage. So the management of non-convulsive status epilepsy is pretty much the same as convulsive status epilepsy but we need a EEG monitor at the beginning because you don't need when is the first when it doesn't like the convulsion, you can see clearly the onset time. And the preferred medication for non-convulsive seizure is pretty similar to the convulsive status epilepticus. So the outcome for the non-convulsive status epilepticus is different in adult and children. For children, for the children with non-convulsive status epilepticus, usually the absence status, relatively there's outcome is better, but you still have to treat it as soon as possible to reduce the residual sequel. So the summary is treat status epilepticus as soon as possible because time is brand. And also, all patients with convulsive status epilepticus should be given a second anti-epileptic drug. And also, consider the non-convulsive seizure in patients who stop convulsion if they do not return to functional baseline. So when you treat the convulsive status epileptic, when you see a patient not convulsed, not twitching, you still have to monitor if it enter to the non-convulsive seizure or not. And the diagnosis non-convulsive seizure require EEG monitor. And also, all patients with refractory or super refractory AC should be managed in an ICU setting and may require EEG monitor to see the effect of anti-epileptic drug. So next week, take a few minutes to talk about acute resuscitation. What is seizure in emergency? It can be a seizure clusters, a cluster of seizure that get longer or occur close together that can be develop one another. So those kind may predispose to status epilepticus. So maybe the seizure, the frequency of seizure increase, you have to aware of that. And of course, the status epilepticus is emergency medical emergency condition. And also, when the patient have seizure with injury or other units, that may be an emergency condition. We may send to the hospital. So this is a risk for seizure emergency. If the patient has diagnosed with status epilepticus before, or has one seizure and after another, so cluster the seizure and the duration long enough, and or if you have started the medication by without medical advice, those are put the patient into the risk of seizure and status epilepticus. So the poor control seizure and sometimes because there's a low level of medicine and drug level is not enough, those are risk for seizure became the status and need to give need emergency care. So let's talk about the first aid for the seizure. When you see a patient with, when you see a man or a woman has seizure, how will you do? How will you do? Anybody can give a, how will you do? I think that you are the number one. How will you do? Yes, three S and two N.
I think the first thing is you
Yeah.
need to ask for help. You need to ask someone like sister speak to you and probably a child or others to believe you.
Yeah.
I think that would be the first thing. Yeah.
And what is no?
Sorry?
What is no? There's a several, three S and two no. What is
Ah,
do not do what?
yes.
What do you think? Do
Uh,
not
Respect.
put your finger in. Yeah, so I think you should you all know that the three S is stay with the person and start timing the seizure because the time is grand. If the patient usually the seizure stop within 1 to 2 minutes, so that's fine. But it not stop within 5 minutes is will be entered to the status hospital status epilepticus. So you should have call emergency to give emergency care, and also keep the person safe. So call the hey, we need help. Yeah, keep the person safe, and also we usually put the person onto the side because when the patient have seizure, there's some vomiters may suffocate. So put the patient to side. This is 3S. And do not put any object in the mouth. Do not put your finger to your mouth. Your finger will shorter. And do not restrain the patient because sometimes the patient moves so strongly and so violent, it can cause some injury. So when to call for emergency help, if the seizure lasts longer than 5 minutes, and the repeat seizure, and the first time seizure, and the seizure occurs in water. So when you're swimming in water or fishing, you drop in the water and seizure, those can cause the drown in the water. So if in water, we have to call emergency. And the difficult breathing and the injured person or pregnant or does not return to Eurostate and ask for medical help. Those patients, those kind of conditions, you have to help to call the emergency help. So this is left side. So I think for the patient, we have to how to manage their epilepsy well. There are several important things. The first thing is to know about your condition, and epilepsy can be treated, and also it's better to have a diary to record your seizure frequency, seizure pattern, and how about the medication effect and the adverse effect, like the pharmacist says, maybe because the adverse effect, the patient want to take the medication, then communicate with your doctors. Then doctors can help you to give you a best prescription to control your seizure. And so remember the medicine. The medication is very important to control your seizure. Compliance poor compliance may cause the patient into a dangerous condition. For example, like the status epilepticus or injury when a patient has do some work, and also the lifestyle. It's better to have regular exercise and enough sleep. Sleep is very important for epilepsy patient. If you not sleep well, sleep too less, the brain activity will become higher and higher. And also the diet. Sometimes we may suggest for the epilepsy patient, especially the children, we suggest to ketogenic diet and do not take the alcohol drink consumption, and also the safety. Be care for the when if you have the seizure, you should have in a safety environment. So that is all my presentation. Thank you for attention.
Thank you so much, Doctor, for your so informative presentation. I'm not sure if there are some questions or some comments that your audience will want to engage on. Is there any? 210. Thank you.
Okay, thank you. So
sometimes when people don't ask